Hi, I'm Cliff Salinger. I practice in the West Palm Beach, Florida area with multiple locations, and I limit my practice to cornea and external disease. So I see a biased population, patients who are either referred by their eye care professional because the eye care professional reaches a ceiling on what it is that they're able to treat and recognize, and or they're self-referred because they're frustrated. Their eye care professional may or may not have diagnosed, evaluated, and determined an appropriate treatment for their condition. Several years ago, I became very frustrated with several dry eye patients. I thought I knew a lot about ocular surface disease. Clean up the lids, get the meibomian glands functioning better, treat the aqueous component, and still, many of my patients were not getting the results, the improvement that we wanted for them, or of course that they wanted for themselves. They were frustrated, I was frustrated. The key was making the diagnosis. And I didn't know what I didn't know until I knew it. And when I found out, and now I know what I didn't know, I realized I was dangerous when I didn't know what I didn't know. Mechanical dry eye is rampant. It's almost ubiquitous in individuals over the Medicare age of 65, and we have to look for it. The key is making the diagnosis. I get fooled still. I look, white light, shining the slit beam across, and I'm thinking to myself, oh, there's not a whole lot of redundant conjunctiva here. I put the fluorescein in, I turn on the cobalt blue light, and then, even better, I put a yellow filter on the other side of the microscope, and it highlights the redundant folds of the conjunctiva, the mechanical dry eye issue that we've now come to learn is significant in the ocular surface inflammatory condition that our patients have. It's necessary to identify and diagnose the mechanical dry eye and have the appropriate conversation with our patient to explain yours is a little bit more than the straightforward dry eye. I present to patients, everyone has 4 components contributing to their dry eye: exposure to the environment, inflammation, quantity of tear production, and quality. You have a 5th component, mechanical dry eye, this redundant conjunctival folds, which by the way is more a problem of Tenon's fascia. It's the inflammatory MMP9s that break down the Tenon and cause it to become loose, disinserted, and you would think that it's excess conjunctiva. Indeed, it's not. It's a shortened fornix. And if we don't address that in our ultimate treatment, we're missing the boat. But going back to how do we discuss it? Surgery is not our first option. We still want to clean up the lids, get the meibomian glands functioning better. We want to treat the aqueous component. We want to educate about exposure to the environment. But then, presenting at the first or second visit, you have this mechanical dry eye component. We're going to start all of these non-surgical treatments. We'll see how much improvement we can get 3, 4, 6 months down the road. We may need to come back and revisit this discussion because your mechanical dry eye likely contributes to your symptoms significantly enough that we may need to consider surgery if we cannot help you enough with the other non-surgical treatments. That being said, I would suggest 25–30% of individuals do go on to require the surgical repair, and the surgical repair again is so important to recreate, restore the reservoir component, that shortened inferior cul-de-sac, much like a kangaroo pouch. If you don't have the depth to it, then there's no room for the little Joey. Well, in our case, the tears that are then drawn up onto the ocular surface with each complete blink, into the meniscus, and then brought up onto the ocular surface with the next complete blink. The most important thing about mechanical dry eye is effectively diagnosing it, realizing that it is contributing to your patient's symptoms. Once you recognize it, then you can have the proper discussion and the appropriate treatment. If you do not make the appropriate diagnosis, you're swimming upstream with both hands tied behind your back. No matter what else you do, you're going to hit a ceiling of improvement for our patient, and they're not going to be happy. The way to build a practice is to make our patients happy so they refer other patients that we can in turn make happy. Key, diagnosis. So, as an example, A young lady in her mid-40s having significant dry eye issues, referred by another eye care professional who had treated the eyelids, treated the meibomian glands, treated the aqueous, but failed to recognize the mechanical dry eye component, all of the redundant conjunctiva that was inhibiting the tear reservoir in the area behind the lower lid that we could not see. We are only seeing the tip of the iceberg, the redundant conjunctiva just above the lower lid margin, interfering with the tear meniscus, interfering with the proper flow from the reservoir up onto the surface. This young lady was really an example to me of how easy it is to overlook the diagnosis. I looked through the slit lamp, white light only, really didn't appreciate much. Put on the fluorescein. Whoa, look at all that mechanical nature blocking the reservoir, and then brought the yellow filter on the other side of the microscope, and it was like, it just jumped out at me. How could we miss this diagnosis? But we have to think about it. Our index of suspicion. So always look for common things like mechanical dry eye. We have to ask ourselves, is it there, is it not? And look for it. I urge every one of our eye care professional colleagues, from Alaska to Maine to Southern California and internationally, please look for mechanical dry eye. If you don't look for it, you won't find it. We only know what we look for, and therefore, please go ahead, look for it, recognize it, have the appropriate discussion with our patients to help them understand and make themselves better.